Welcome to Back from the Abyss. I'm Dr. Craig Heacock. Today I'm doing a solo episode. This one is called A Scary Med List. As many of you know, in addition to my clinical practice, I have a number of projects. I do this podcast. I do intensive psychotherapy trainings. I work with elemental psychedelics, doing psilocybin and ketamine-assisted therapy training. And I also do case consultation with psychiatrists, psychiatric NPs, PAs, and therapists from all over. My difficult case consultations often hinge on psychodynamic issues like transference, countertransference, the fears, the doubts, boundaries, playing too nice, peacemaking, or thinking medically rather than thinking holistically or psychologically. I often find that clinicians are too eager to talk treatment options rather than slow down. We need to look at the big picture, see if the story makes sense. Then we also need to look inward to see what the difficult case or patient is pulling up in us. What is the nature of the dysregulation, and what does it say about the clinician and their particular countertransference? But today, I wanted to share with you a different kind of case. This is a case that I think highlights exactly what's wrong with American psychiatry and this medication management model that so many people are using. Now, it's really tempting for me just to jump right to the med list, the scary med list, but let's start with some background information. So this case comes from a psychologist that I've been working with the last few months. She brought me this case a couple months ago. And my first memory was she said, I think this patient is on some scary meds. So yes, she is so right. And how ironic how that a psychologist, now granted, she is in training to become a prescribing psychologist in Colorado, so she's actually very adept with meds already, but this case is being managed by a psychiatrist, and the psychologist had to point this out. All right, so let's dive in. I'm going to change a few details to protect confidentiality. So we'll call this a middle-aged professional woman. And as my mentee said, she's just stuck. She's not getting better. She's stuck in just feeling terrible, stuck in alcohol and cannabis abuse, can't sleep, feels terrible, depressed, anxious, and miserable. She has a significant trauma history, probably a mood disorder, unclear, putative/possible ADD, and no apparent history of any manic or psychotic symptoms. And my psychologist mentee has been seeing her for years, so no history of anything like that. And importantly, I'm going to argue, this patient is at least 100 pounds overweight. And as I mentioned, she's got significant alcohol and cannabis issues, although the psychologist wasn't clear exactly how much she's using. So let's stop right there. 100 pounds or more overweight should send off medical alarm bells. So let's take off the psychiatric clinical hat and let's put on the medical hat for a moment. Anyone 100 pounds or more overweight has sleep apnea until proven otherwise. Studies suggest that 75 to 95% of patients who are at least 100 pounds overweight have sleep apnea. Now, you listeners know how critical I think sleep is. Sleep is the great mood stabilizer. It's the foundation of psychiatric and medical health. Yet, this patient has never had a sleep study. It's unclear if she snores, although she does apparently have a very chaotic sleep schedule. And of note, she's been trying to starve herself now for months to try to lose weight, but she's actually gaining weight. Central to making what's called a differential diagnosis is that we have to consider and address underlying medical problems before addressing possible psychiatric illness. So I think it's fair to say that we can safely assume that she has some degree of obstructive sleep apnea, which would mean that she's chronically sleep deprived. She's not getting sufficient deep restorative sleep, and that would lead to slowed metabolism, to daytime sleepiness, brain fog, carb cravings, mood instability, anxiety, insulin resistance, and probably substance cravings. Sleep apnea is perhaps the most common undiagnosed, untreated medical problem that presents to psychiatric clinicians, with vast and disabling psychiatric ramifications. And most importantly, and this is critical to this case, Psychiatric meds are going to do little to nothing for a patient with untreated sleep apnea. This patient has a psychiatrist that she sees every few months for a 15-minute med check, and many of those sessions, I think, are by video. Okay, so let's look at this strange and scary and naive and harmful list of meds. You might want to write this down to really soak in the insanity of it. Okay, number 1, Adderall, also known as amphetamine salts, immediate release, 90 milligrams. What? Number 2, lurasidone, Latuda, 120 milligrams. Quetiapine, also known as Seroquel, 300 milligrams at bedtime. Clonazepam, 1 milligram at bedtime, also known as Klonopin. Gabapentin, 600 milligrams in the morning, 300 milligrams at night. And lisinopril. So that's just a short little list. Let's see. 6 meds. Shocking. And I think we're going to dive in deep here and see just how nonsensical and counterproductive and even, I would say bordering on malpractice this med list is. Now, first of all, I would strongly argue that we should be able to look at a med list and have at least some idea of the putative psychiatric diagnoses. So let's have a look med by med, dosage by dosage. What can we learn? Okay, number 1, Adderall, amphetamine salts. Maybe she has ADD. And I mentioned that in the case description, that she has putative ADD. Well, there was a really nice review on the Carlab Report podcast in 2024 where they looked at the data with amphetamines, methylphenidate, and ADD treatment. And the research data is clear that over 35 milligrams of Adderall equivalent, efficacy for ADD steadily plunges. This woman is on 90. So I think we can safely say that if she's on Adderall, it is not for ADD. She's on, depending on which FDA recommended maximum dose you look at, she's on about twice the recommended maximum dose that the FDA puts out there. This is a dose, when I see a dose like this, first of all, I think of this as a malpractice dose, but I wonder, A, is she addicted or dependent? B, is she selling it or giving it to people? Or 3, is she so groggy and out of it in the daytime that she needs to hit herself with speed? Because, let's call a spade, Adderall, amphetamine, is speed. And sometimes people need speed. And low-dose speed actually can be very helpful for ADD, ADHD. But what happens is you get on higher doses of stimulants, and I've talked about this at length on other episodes. When you go above, say, 40 milligram equivalent of Adderall, you start getting into insomnia. Because guess what? Speed wrecks sleep. And not only is sleep the great mood stabilizer, it's the cognitive reboot every night. And I think what we find, those of us in the trenches doing this work, people coming in on high-dose Adderall are getting terrible quality sleep because they're jacked up on speed. So just from the very first med, we can see this woman is on a crazy dose of Adderall. And the other question I would have is, why is she on immediate release? In my opinion, immediate release Adderall should probably not even be on the market. It's the most abusable form. It's the one that you can sell for the most money. You can snort it, you can shoot it. So that seems really irresponsible that the psychiatrist is giving her that. Okay, let's go to the second med, lurasidone. Lurasidone in the US is also called Latuda. Lurasidone is an interesting med. It below, say, 40 milligrams, it really has antidepressant effects. From, say, 40 to 80 or 100, it has mood stabilizing effects. Above 100-ish, it's an antipsychotic and an anti-manic drug. So she's on lurasidone 120 milligrams, which would suggest that she has some kind of psychotic illness and or bipolar 1. But her psychologist who's worked with her for years has said there's no evidence that she has any diagnosis like that. This is very strange. Let's go to med number 3, quetiapine. Similar to lurasidone, quetiapine is used for different diagnoses at different dose ranges. So say below 100, quetiapine is a good med for insomnia, anxiety. Say quetiapine 200 or 300 milligrams is often used for bipolar 1 or schizoaffective disorder. And then occasionally quetiapine is used as an antipsychotic above like 500 or 600. So basically our patient is on a bipolar 1 or schizoaffective dose of quetiapine. She's on a big dose. And so let me just give you a sense of those who don't know quetiapine. It is now 12:54 in Colorado in the afternoon. If I took 100 milligrams of quetiapine right now, I would probably sleep for 14 hours. And I'm someone who doesn't nap very well. 300 milligrams of quetiapine is a big, super sedating dose. It's a dose for people with bipolar 1 or schizoaffective disorder. But by all accounts, this woman has neither of those. Okay, let's go to the 4th med. She's on clonazepam, Klonopin, a milligram at night. And that doesn't sound like much, 1 milligram. That sounds small. But remember, clonazepam is 4 times as strong as lorazepam, Ativan. So she's actually on the equivalent of 4 milligrams of lorazepam at night, along with quetiapine. Wow. Why? What the heck is happening that this woman needs to be clubbed at night with 300 milligrams of quetiapine and 1 milligram of clonazepam? Next med, gabapentin, used for anxiety primarily, pain. Usually if it's dosed 2 or 3 times a day. The bigger doses at night because it can be sedating, but she's on her bigger dose in the morning. So while she's starting off on her very large doses of speed, aka Adderall immediate release, she's also on gabapentin. Is that to counteract the high anxiety associated with Adderall? I don't know. And then finally, she's on lisinopril, blood pressure medicine. Again, I'm wondering how much of that is related to her meds, like Adderall cranks up your blood pressure. Guess what? Sleep apnea greatly increases your blood pressure, and being overweight increases your blood pressure. So anyway, I posited that we should be able to go through a med list and look at the psych meds and have a sense what someone's putative psychiatric diagnosis would be. Who knows? You know, when I look at these, I see, okay, we have no idea. But what we do know is that she's getting hammered with the accelerator in the morning and she's getting slammed with the brake at night. Amphetamine in the morning to wake up and get her moving, and then slam her with clonazepam and quetiapine at night to put her under. What diagnosis could these meds stand for? I'm thinking the most likely scenario is this is the med list for people with undiagnosed sleep apnea. Because here's the thing, sleep apnea wrecks you. You're chronically sleep deprived. Oh, if you can take some Adderall, it's so nice. But the thing is, Adderall, you build up a fast tolerance to it. When you take Adderall for its speedy effect, you quickly build up a tolerance to that, so you need more and more and more. In fact, you tend to have to go from extended release to immediate release so you can really feel it. So she's on a ton of speed. In fact, I would argue 90 of immediate release Adderall is approximately equal to 2.5 to 3 grams of cocaine a day. And then she has to be knocked out at night. Why? Well, she's so sleep deprived, you would think that she wouldn't need anything to knock her out. But what happens with sleep apnea is as soon as you start to go into deep sleep, your airway collapses and you start to suffocate, and then you wake up as you snore yourself awake. So ironically, people with increasingly severe sleep apnea tend to end up on a lot of sleep medication. But then you see what's happening is the sleep medication actually can be counterproductive, and it keeps people knocked out longer. So I'm going to do an auditory imitation of sleep apnea. So what happens with sleep apnea is you stop breathing, and you wake yourself up with this gasping, adrenaline-driven diaphragm movement. But if you're on a bunch of benzos like clonazepam and or quetiapine, your respiratory drive is dialed down. You're super sedated, you're obtunded. So your apneas are much longer. So ironically, these people with undiagnosed sleep apnea, they often get put on a bunch of heavily sedating meds at night, which effectively are increasing the length of their apneas. And again, the longer you're depriving your body and your brain of sleep, you're greatly increasing your risk of anoxic brain damage, of heart damage, strokes, and overall misery. So could it be that this woman who's being managed by a med-check psychiatrist for God knows what, given these meds, actually she's being managed for undiagnosed sleep apnea? And because he's so, I don't know, uncurious or busy or time pressured or just not willing to think out of the psych med box, he's not seeing what's staring him in the face. He keeps hitting the nail with his one instrument, his one med management hammer, and it's not going in. Maybe we should step back and ask, what the heck is going on? Back to this idea of this poor woman starving herself to try to lose weight. So her med list and her undiagnosed sleep apnea is wrecking this for her, because let's just go through her meds. One of the side effects of Adderall is it decreases appetite. But as Adderall wears off, you get extremely hungry. So what happens to people who are taking big doses of Adderall is it's finally starting to wear off at night. They get ravenously hungry. So if you look at the calorie intake of someone who's on Adderall, they typically are taking in most of their calories at night. And interestingly, most people say that Adderall makes them both crave carbs and alcohol, especially at higher doses. And then she's on quetiapine, an atypical antipsychotic that is infamously bad for women in terms of metabolism, weight, and risk of diabetes. Now, I would only use quetiapine in a woman who I also had on metformin or one of the GLP-1 agonists, something to try to counteract that. Now, maybe what the psychiatrist is doing is he figures if he gives her enough speed that will counteract the quetiapine. But the problem with that is the Adderall is wrecking her sleep. So this woman's starving herself as she's deeply sleep deprived. She's almost surely craving more alcohol and carbs in the evening as her Adderall is wearing off. She's on a med, quetiapine, which basically makes it impossible for a woman to lose weight. And she's using alcohol in excess, which is a carb, and carbohydrates make you crave more carbohydrates. So in general, alcohol tends to make people hungrier. And we know that cannabis, especially cannabis abuse, can really disrupt appetite. And we also know that restricting food intake tends to make people crave calories more. So sadly, this woman is working so hard trying to hold her breath, essentially, and not breathe, when everything that's happening metabolically, diagnostically, and medication-wise for her is pushing her in the wrong direction. And actually, again, this is a really important thing to note, the quetiapine-clonazepam combination is potentially putting her at risk of sudden death. So what are my parting thoughts on this case? Oh, man. Let me just sigh. Okay, number one. Psychiatric med management can do significant harm. Now let's shoot straight here. Adderall is speed, and I mentioned this before, and sometimes it's helpful to prescribe speed, but at low doses, in extended release forms, and with very careful monitoring. And prescribing high doses of immediate release Adderall to someone who you suspect is abusing other substances, that is malpractice, in my opinion. What is this person doing? Number two, we Psychiatric clinicians need to think like physicians. We need to think holistically, not just what psych meds we can pile on or what symptoms we can manage by changing doses. We need to think holistically. We need to rule out medical causes first and only then move on to psychiatric etiologies. Number 3, if an outside medical observer can't reasonably guess the diagnosis from looking at the psychiatric med list, that's a serious problem. Number 4, if you are prescribing outside recommended FDA max limits, especially with controlled substances, you better ask yourself why. What are you trying to do? And number 5, a final thought, both for psychiatric clinicians and for those of you who interact with psychiatric clinicians. If you hear a psychiatrist or psych NP say, I just do the meds, or I'm just the prescriber, or that's something you should talk about with your therapist, run for the hills. Get out. Toss your pill organizer and hit the road. Thank you, everyone. That was Scary Med List, my first solo episode of 2026. I just want to say one final thank you here before we wrap up. I just got an email recently from a listener named Gordon Banner. He's a big fan. And he made a searchable index for Back from the Abyss for all 7 seasons. Now, this is something Chris has been suggesting for years. Chris is like, we should do this, we should do it, we should do it. In any case, I put a link to it in the show notes. Maybe you all can play around with it. Gordon and I would love any feedback, how to make it better. But basically, it's a way to look back at all the different episodes and seasons of Back from the Abyss and search by topic and title and storyteller. And it's actually really cool because I think one of the things that I love most about Back from the Abyss is there's so much wrapped up in it. There's stories and expert opinion and funny stuff and sad stuff and pearls of wisdom. And sometimes it can be hard to figure out where to start. So anyway, please reach out to me, craigheacockmd.com, if you have any thoughts on what Gordon's put together. We'll be back in 2 weeks. Thank you for listening.